some very complicated, well, on our end, it seems complicated. On the surgical end, it's probably some of the more simpler guides on the market with chrome guided smile and maybe even some of our plastic guides. Try to keep it simple. But we're going to go into the chrome system in a minute. But before we do that, I want to cover what we call the tool. I call it the tools of the day, but really I call it trick my surgical suite. And so what am I showing here? I've had the pleasure of going to many offices in the past several months. It's been wonderful. I go chairside and do conversions with doctors on chrome, on some of this new small hole technology that we're going to show today, on how to do extraoral conversions and teaching. And it's just been a lot of fun and a very educational, and been able to bring a lot of this, a lot of information back to the laboratory so we can share with doctors. But what am I showing here? It's kind of silly, but on the left is a fully tricked out Jeep, and on the right is a partially tricked out Jeep. What's it missing on the right? It's missing a winch, and it's just one of those tools that you really need if you're going to do this type of thing. So this Jeep, he's just spinning his wheels, right? He's in here for a long time, spinning his wheels. He's got an issue. His issue is he's stuck in mud. I'll silence this, but he's stuck in mud. And how's he going to get out of it? He needs a tool, and he needs a right tool, specific tool. And in this case, it would be a winch, tie it to something and pull your Jeep out of the mud. Is this a silly reference? Yes, but it's meaningful. And so what I want to do is go through a lot of the tools, that I think a doctor needs if they're going to really get into complicated surgeries, full arch surgeries. I'm amazed sometimes just how many tools are in some offices and then how few are in others. So let's go through them. This is just kind of a catch-all summary, but I'm going to go through some of the ones that I think I find most important.
Oh, 50.
So he says, so if it's 50, we'll get 60. So with a lot of tools, a lot of wrenches, it may not have a torque on it. It's just a ratchet, and it's ratcheting down the implants by feel. And that works well, especially if you have ISQ. And so you're using torquing for one aspect and then using ISQ for testing. But it's nice to have a, let me just turn the volume down, but this is a breakaway. This is the one here on the left. So the doctor will set the torque on the torque. You see it break? So it'll give at each torque level. So he'll know when he's at 45, 50, 60, et cetera. And once he gets to a certain mark, then maybe you just ratchet it in. But, there's an argument for all this ratcheting and torquing that maybe it's better just to go to depth and do an ISQ reading. So there's a little philosophical on that, maybe some science behind both of them. But it's nice to know where you are, what torque you are when you are finished. So that's a nice tool. You can use the Meg Torque. Really, Meg Torque's more for prosthetics, but certainly you should have the torque wrench of the company, right? Because this is abutment screws 35, prosthetic screws 15 in the Straumann system. So this just reminds you of the two. We actually sell a torque wrench that you just dial the little handle here, and you just turn the knob. It's a contra angle. So you turn the knob until it breaks, till it gives, and then you're at the right torque. It's very, very important to be at the right torque, especially on the prosthetics. Been chair side where prosthetic screws break. And when you're in a surgery and that happens, that's a real problem. So you can swap an abutment out, but if you're locking prosthetics in, that kind of thing, it's a problem, or even having trouble getting abutments out. So very important to have that right tool. Another one is the ISQ. Maybe half the offices we go to have the ISQ reading. I think it's a very useful tool. It's what they really say. It's a substitute for tactile assessment, as you can see down here in the bullet points. It's you feel like it's 45, you feel like it's 55. Maybe you go by torque, maybe you go by ISQ, but the ISQ is going to tell you, it's going to tell you this resonance frequency analysis, which is the implant stability coefficient. So it takes readings and it tells you how secure, how sturdy the implant is in the bone, and whether you should load it or not. It gives you an actual number. So if you're above 65, between 65 and 75, then you load. If you're down below that, if you're in the 60s, 50s, you don't load. And so it's a yes, no. Sometimes with torquing, it's a maybe, right? Well, I got 20 on this one, but I got 45s on all the rest of them. Do I load the 20 or not? Well, I do my math and add them all up. And the ISQ would just say no. Another tool that's handy is to have a tissue punch. And because I've seen the scalpels, I've seen manual punches, that kind of thing. This one's awfully nice to have on the handpiece. It just spins around an MUA and opens up the tissue. Because if this is a full flap reduction, you're bringing tissue from the labial-lingual, putting it over the MUAs. And I'm just kind of summarizing. There's a whole conversation about this, but rather than use a scalpel or use some unique suturing techniques, instead of trimming tissue, use a tissue punch. It's the right size, works really well. So it's very, very handy to have. Bone burrs. With these cases, you can see in this video here, there's a lot of bone reduction with a lot of these surgeries. And to use a little burr, and the little burr takes a long time. Now, little burr, you can do little bone holes and then use rangiers, and you can be pretty efficient with that. But when it comes to really a gross bone reduction, when you want to come to gross bone reduction, which is very, very common, you want a very aggressive burr. And again, like a lot of these videos and slides we're talking about, there's a conversation. I realize that. But if you're going to have to reduce 4, 5, 6 millimeters of bone, perhaps it's rangiers first, and then it's one of these burrs. These burrs make a big mess. It's like bone snow everywhere. But you can see the shape of these burrs. And when we are in a full arch surgery, we want a flat ridge. When we're doing an FP3 type surgery for a prosthetic, you want a flat ridge. The Meisinger burr is brilliant. It's a barrel shape. And so is Mr. Hungry, we call it Mr. Hungry, the Comet burr. Because they're flat, then obviously the bone is going to be flat. It's going to reflect it. Historically, we've seen football shaped burrs. But with a football shape, you could end up with a concavity on the ridge, which you don't want. If anything, you want a little bit of convexity. You don't want a concavity. And with these burrs, it's flat and it's very efficient. These burrs, you almost have to hold the burrs back. They cut so well. So that's one of the very important tools, and a great set of rangiers. I know some of our KOLs use these Frings systems. They have an integrated spring inside of them that opens up. Nice product. They have a whole line of tools for surgeries, but certainly want a good set of rangiers because removing the bone and saving it, and grinding it up for bone grafting is advantageous. So a good set of rangiers. This, of course, I have put up here is optional. Bone saw, and a bone saw it's tough to watch. I've been in a few of these surgeries. It couldn't be more efficient. If that bone's coming out for whatever reason, the most efficient way to do it is a bone saw. It's clean, it's fast, and then you move on, because this could be an hour of extraction, reduction. Bone saw is done in a couple of minutes. It's not easy, and it definitely takes some training, some practice to make sure the bone, that the saw is going in the right trajectory, because you can overcut, on the lingual. So the other thing that's really important if you're taking on big cases is surgical guides, surgical guide kits. And there are many, many on the market. We work with just about all of them. Because they update and they roll new ones out frequently. And we always have the guide sent here, or we purchase one. We have something on hand to verify our guides. But this is very important. There are some universal kits. The Blue Sky has a really nice universal kit. And I believe Anatomage does. We don't really work with Anatomage, but they have a nice universal kit. And there's a few others out there, but our recommendation is to just purchase the guided kit for your system. There's no reason not to. You might find that, well, we're going to get into this partially guided versus fully guided, because that's really important thing to know. Not all of these, not all kits are fully guided. And what I mean by that is, does it drive the implant? Okay, they all drive the drills, right? That's what they are. They're guided kits for drills. But when you're done making your osteotomies, can you guide the implant into place? Many of them don't. So this is a Nobel system here. And this is a mount on the implant. The mount fits inside of the osteotomy guide. You can't deviate from it. So you got the implant in the right position. This system here, and I'm pretty sure I know the system. I won't mention it, but you can see that the driver is not intimate with the osteotomy guide. And so it's visual. And so the doctor is just kind of trying to keep this implant in the right trajectory while trying to maintain the center of this osteotomy guide. Well, that's partially guided. And really for these types of cases, if you're off by 1 millimeter, 2 millimeters, and we've planned for the screw access hole to be precisely in the middle of a bicuspid, then the trajectory, depth, and rotation are imminently, are extremely important. So fully guided kits are better. Now, the other thing to consider is spoons and sleeves versus just a hub design. Notice on the right, this is a MegaGen kit. There are many like it now where there's no spoon. So we design a guide, whether it's chrome like you're seeing here or any type of guide. We design a osteotomy guide that the drill fits directly into. There's no spoon. This is a Nobel, there's a spoon. Many systems still have this. I'm not going to direct one way or another. These are a little bit simpler, but some preference there too. And there's reasons for one over the other. But the one issue with sleeved is that inside of our guide is a sleeve, and maybe sleeve, but then inside of the sleeve you insert a handle, a tool, so you have a little bit of variable there, and then inside of the tool is the drill, so you have a little bit of give here, a little bit of slop here, and maybe a little bit more because there's a sleeve. Now you see that little bit of slop times 3 could lead to a little bit of variation of where the implant should be, okay? With these guides, you're still gonna have a little bit, right? These are not machined perfect. It's not the automotive industry. So you're gonna have a little bit of play, but just not quite as much we found. Just an example of actually a really nice kit that does use spoons and keys is a Straumann kit. This is a BLX kit. You can't really see it here, but inside of our sleeve, oh, you can see it here. Here's a peak insert. So this key locks into this insert. This is a hands-free, which is really nice, because one of the issues when you're in guided surgery is the assistant or the doctor is holding onto the spoon, doctor's drilling, somebody's holding the mouth open. You've got 4 hands in the mouth, one of them just to hold this spoon down. So this spoon locks in. It's pretty nice. Actually, I took this picture a couple months ago. Kind of just stood out, you know, the doctor just clicked it in, turned around, grabbed the drill, and then started drilling. So it was a nice process. So these are fully guided and partially guided. This goes back 2 slides ago. But fully guided, where the doctor is placing the implant through the guide, is these companies here. And I think there's more. And this side is really partially guided. So with a Zimmer case, you're drilling, but then the implant does not fit through the spoon or intimately through our guide. Implant direct the same. So be happy to talk with anyone, speak with anyone about their kit, or if you're thinking of buying a kit, call us, we'll talk about it. Especially as it relates to an implant that you already have. This goes with the two slides ago now, which is the sleeve system, the spoon system, or the hub. So I've used a couple different terms, but drill hub means that you have a drill and you have no spoons. So all of these companies have come up with drills only. These companies use a sleeve, a spoon or a key like this. And then these two have a sleeve and sleeve, and there is play in these. You know, you have a sleeve in here, and then you got a sleeve, then you got a drill. You have a little bit of play, similar to spoons, but I think it's a little bit more of a little more play. And these can pop out when you're in surgery because they're not glued in. You just keep dropping sleeves in until you get down to the small size. Another tool to have is bone profiler. Have to have one, especially if you're doing, you're going to be doing angled implants. Sorry, I kind of have the image here hidden, but when you have an implant that's subcrestal, then you need to widen the bone above it so that the abutment will seat, because the little bend here, this little part of the abutment will not seat because the bone is in the way. So you have to open it up. And so you'll see this is a Straumann. This is a profiling kit. And the neat thing is you can see right at the end how when it comes out, that little sleeve here, this is screwed into the implant. And then you just simply, it's guided. So you just simply place your profiler over the sleeve and go down to depth. And this is basically a countersinker, and it profiles the bone away to make room for abutments. Nice tool. Most systems have a profiler, but a lot of them are freehand. Some of them are guided. I would not purchase a profile that didn't come with your kit for your implant company. I wouldn't buy a generic one. This is just very, very precise work here. It's also usually about midway through surgery, maybe a little bit longer into it. You don't want any problems. You don't want something that's going to touch the top of your implant and ruin it, right? If this is not guided, those little cutting burrs can hit the top of the implant, and then you're removing the implant and starting over on that site. One thing I've noticed in surgeries is that often the office is ordering for the day, for the surgery, for the patient. That's it. They don't have an armamentarium of implants, collar heights, angles, extra abutments, extra implant lengths and widths. You have to have it all. If you're going to take on these kinds of cases, you just have to. I can't tell you how many times we have an implant that just doesn't have torque and you want to go bigger. You decide that because of bone reduction or a sinus lift isn't going right, you want to go shorter and wider, but the implant's not on site. So the doctors who do a lot of implants, and I find this both GPs and specialists, have an armamentarium, a backup to your favorite implants. Because one other thing that's really handy to have is a plan when you're going into the online meetings with us and planning your case. If you've got 5, 6, 7, 8 implants, try to make as many of them the same width and length. Because in guided surgery, you don't have to look up at the report 30 times while you're drilling. All my implants are 4.5 by 11.5, all of them. And it's a beautiful thing. It's also nice if they're all straight. That's not quite as common, but if you could make a little bit of a sacrifice on the size, or maybe you could bump it up for, somehow, then try to get them all the same. Boy, is that easy to drill. One drill all the way across, next drill, et cetera, up until you're at full size. So often I see mixed matched, 6 implants in an arch and 5 different implant sizes. And it's just a lot of thinking and drilling. Another thing to have is kind of a tool is to just to remember that you can do angled screw channel with a lot of systems out there. And angled screw channel allows you to put implants in more desirable positions and disregard sometimes the position of the screw access, because you can now come out the lingual, you can come out the middle of a bicuspid or molar, even though the implant trajectory is off, and you can still use straight multi-unit abutments. So just keep that in mind when you're planning, and if your system offers angled screw channel, take advantage of it. It's the neatest thing. And then something that's really advanced that we're working with a lot now is making prosthetics with no copings, just using special screws. And this is also another advantage. You think about the big picture of this. No copings to come out, no copings to fall out. The coping doesn't take up space. You can make your prosthetics thinner because you don't have all that material of metal and cement. And it's also more hygienic. So this is a Nobel Procera bridge. We've made many with no copings, direct to implant. Direct to MUA. And if it's a Nobel, it can be direct to implant, Nobel. But for any other Nobel compatible multi-unit abutment, consider a Nobel Procera bridge. It's been around for a number of years, thousands of cases. We've made many now. You'll see these dominoes, and I'm not going to spend any time on the dominoes, but if you have a lot of full arch in your practice, you're doing a lot of full arch surgery, you should consider the ICAM 4D scanner, because it delivers a perfect position of an implant and multi-unit abutment to us, for us to make prosthetics with no copings, no models. Actually, you can see in the blue there, no copings, no models, no articulation, 100% digital. There's nothing like it. And on our website, you can watch a whole video that we did last month on this technology. Good stuff. And then just some other accessories. So I kind of go through a list here. I don't want to insult anyone by saying this, but I want to put this in the list anyway. So bone grinders are handy. PRP, really nice to have for grafting and immediate. Anesthesia, sedation. I see about half and half for some of these full arch cases, half sedation, half the time we're talking to the patient while it's going on. Kind of crazy. I don't mean crazy as in bad. I just mean it's always kind of crazy to be chairside having a chat with the patient while they're going through one of these surgeries. Definitely highly trained surgical assistants. That's a big deal. Certainly makes things go smoother if they've accomplished a lot of these cases with someone. Abutment removal tool. If you have any abutments with Morris taper or anything that has a connection that's going to lock it in, you have to have abutment tool removals, or you're really kind of stuck, so to speak. Not even so to speak, you're stuck. You have to have a whole kit of screwdrivers. Every screwdriver out there. There used to be the time when maybe there were 2 implant systems in the practice, but now there's 10 walking in the door. So you can purchase something from Preet, Implant Buddy. You can buy these all over, every driver. Backup drills, absolutely backup drills, especially if you're doing full arch cases. You want to have even a whole second guided kit on hand, just in case. This is kind of smug, but I put an oral surgery who likes you and is nearby. You always want to have an oral surgeon or a specialist who can help you if it's a real pickle. So I throw that in there as things to have on hand in your back pocket. Emergency plan, of course. I won't go into the stories. We have some, and they're scary. Being in these surgeries, ambulances and so forth, tough situations. So have emergency plan. Something happens, you got to know what to do. Always good to have a lab technician who has some all-NX experience if you're taking on these kinds of cases. We come chairside, but if you have a local person, even better. And then always have a plan B.